like to request Professor John Marshall to be on stage. We just want to ask you questions. Professor Belin. It looks nice, so the stage is empty otherwise. And this is going to be an hour of optics of presbyopia. It's a free all. Anybody can raise your hands and ask questions, and then we have some cases which we can discuss. The first question I want to ask you is, we read a lot about presbyopia during our post-graduation days, Duans, Duke Elders, and all that. And today's, our understanding of presbyopia is slightly different. Do you think it still holds good, or we had to relook at our understanding of presbyopia itself?
It's too much echo. We didn't quite understand.
There was this funny thing about Rahul Gandhi and somebody else speaking, and that gentleman next to Rahul Gandhi was not able to hear anything, and we all made joke of him. I think this is exactly what was happening. Remember, I don't know, that WhatsApp thing? Yes, yes. I was just telling whether presbyopia has to be re-looked at it now from what we have already always understood. Because you...
Well, I definitely think presbyopia needs to be looked at again. It's interesting. Aging is a process that happens to other people. And every morning when you, as a man, shave, it's the same person in the mirror. It becomes slightly out of focus. But when you look at your wedding photographs, you think, my God, my wife married a stranger. So aging is a very subtle process. And presbyopia, I think it's going to be a very exciting time, because now we're beginning to understand the genetics of ocular control mechanisms. I feel sure, and I would predict, we are going to be able to slow down the aging process in different parts of our body. So I actually look forward to a genetic control intervention in the presbyopic process. All of us want to be rejuvenated, I'm sure. So that would be my approach.
So you believe that it is a gene which makes some of us get presbyopia early and some of us get it later?
This is hopeless.
Do you think it's a genetic which makes some of...
No. All of us are controlled by genes, and our individual aging process is a genetic process. Some people age very rapidly, some people age very slowly, and different tissues age at different rates, and there are environmental factors and other things. But I think that presbyopia is one of those areas where at the moment we think there's behavioral elements, that if you read a lot, use computers, etc., that's the environmental element here. But you know, I didn't need a correction until I was in my early 60s, whereas my wife needed a correction in her mid-40s, which is more typical. So if we can understand those processes, I think that's an exciting future. And I know that your group is working on a number of different genes. I just want to be more ubiquitous. So I actually want to be rejuvenated.
So John,
and one thing I should comment on presbyopia, just one thing. Our maker has thought about this process very well, because most of us, middle age is when your age shows around your middle, and it stops people going out of focus. So I think that's a good compensation.
are you suggesting that being married to you causes premature aging?
Absolutely.
You need to put it a little closer, please.
Okay, for those who didn't hear my obnoxious comment, I was asking, are you suggesting that being married to you causes premature aging?
Well, you yourself know, sitting next to me on an aircraft certainly ages you.
So one of the things about just the eye in general is it's accessible to external medications where other parts of the body are not. So I would envision at some point in the future we will have a way of slowing down at least the eye aging process.
Yeah.
So I'll come closer to you. So you believe that so you believe that our understanding of presbyopia, what is being taught as a geometrical optical way of presbyopia, has to be re-looked at.
I don't know that it has to be re-looked at. I think we're going to have ways of modifying the lens aging process. And again, I think because, again, the anterior segment of the eye is readily accessible to medications.
Samresh, can you, from your eye trace, if you just pick up some patients where you can show some aging change? This is very important. I'll come to why it is important in our practice. Very important in whether you're giving a presbyopia glasses, progressive glasses, you're doing a refractive surgery, because aging for us as a presbyopia, for us it's been drilled from the time we enter medical school. That is, at 40 you become +1, at 45 you become this. And that has something been into our DNA, and we just cannot take it out. So if you plug it into the system and tell us how do you study the aging of the lens without really looking at the, pardon?
I'll just open up a patient.
This is the software with one of our, you can just.
Yeah, so this patient. So we'll start with this patient, sir. This is from your clinic, so I just saw this patient. And
you can just briefly give an insight into the eye trace, why it is important, because these are our modern tools. And most important thing is, none of us here have any great financial interest in any of the tools. None of the companies come to us to give us money to do anything here. That's the biggest financial disclosure. And some of us, including myself and a lot of us, love lot of machines. And with a lot of love, we may bring out our over-excitement. It does not mean that we have any interest to this. So this whole of meeting is completely free from any financial disclosure. And if you feel that there is something which you feel we are not disclosed, please let us know.
So we are now discussing the eye trace. It's an aberrometer, one of the newer generation aberrometers. And it's a combined topography and aberrometry at the same time. It's a combined machine. So just to give you a perspective of what it does, unlike many aberrometers in the market, the more commonly used initially were the Hartmann-Shack aberrometers. This one is called a ray tracing aberrometer. And what it essentially does is, if you notice over here, there are 256 points. And each point is thrown into the eye, and its image is captured on the retina, or where it lands versus where it should have been. Now, if in an ideal optical system, the light, if it goes through the cornea, through the lens, and onto the retina, will strike a right point. But because we are not perfect, the light deviates and it puts at a different point than what's intended, and 256 such points are mapped out. Once it maps out, then we get sort of a retinal spot diagram where we know how where the light focuses. Now again, this patient, this is a patient who's listed under a LASIK group, but if you notice that all the points are not adding up to form a single point source in this, but it's sort of like an aberrated, irregular profile in this patient. This is the aberrometry part of the machine, and it gives us the total eye aberrations, or how bad the total eye is generally in terms of its optical quality. Now it also, just to go back to the same patient, it also has a topography, placido topography attached to it, and the placido topography gives us all the data that a regular topography would give of the steep and flat K. It gives you the meridians, it can give you all the different curvature maps as and when required, and it also gives you the aberrations of the eye which are derived from the placido topography, and the corneal aberrations that are derived from the placido topography. So it has two machines, cornea and entire eye. So if we combine them both now, so we pick up a scan over here, which is the wavefront and the topography scan, and we run the machine's diagnostics to what is known as a Chang analysis, which is my preferred screen on the machine. It looks really complicated, but essentially to break it down, the bottom part is the topography, the top part is the aberrometry. So this is the total eye aberrations which we picked up using the ray tracing. So we know how bad the entire eye is. This is the corneal aberrations we picked up from placido topography. And if you do a simple subtraction of corneal from the total eye aberration profile, you get what is known as the internal aberrations of the eye, which could be anything right from corneal stroma all the way up to the retina. But for most practical purposes, in majority of the cases, it turns out to be the lens. And so such is the power of these good combined machines, that they can help us break down the eye into corneal optics and internal eye optics, so we understand what actually is going on inside the eye and what is the source of the problem and whether or not it has a cure. So this is a patient, coming back to this patient. This patient has come to us for a LASIK workup. Not a very old patient, mid-40s I think, and this is the refraction. So it also has an autorefractor. It gives you a multi-zone refraction, which is very interesting of the new machines, because as our pupils enlarge, we have a myopic shift because the cornea opens up, and the corneal aberrations, particularly the spherical aberrations, cause us to have better near vision but poor distance vision. And that is what exactly is happening. In a 2 millimeter pupil, this patient is at a -4, turns out to be about a 6.5 and a 5.5 millimeter pupil, which is the scan size that has been done in this patient's eye. Now clearly the refraction shows red. And if you notice, the cornea is okay, there's a regular astigmatism, but there's a lot of chatter coming from inside the eye, which is causing the entire eye optics to look bad. To make it a little easier to understand, you sort of have a simulated visual acuity chart where you look at the different points, join up these point spread functions of each point, and sort of come up with a software algorithm to show. Now one of the good machines that shows this is this. It tells you how the patient is seeing. And you can also see what happens when the patient sees without any glasses, which is sort of now, once the software runs it through. This is how the patient is without any glasses. So clearly this is not a patient you can do LASIK on, because there's something definitely happening inside the eye. And this patient is most likely to be developing a cataract which is not clinically visible, on a slit lamp evaluation at least. So this machine also has an added software called dysfunctional lens index, which I don't know how they're doing it, but essentially it grades the lens based on the aberration, internal aberration profile of the eye. It grades the cataract as a grade 3 and a dysfunctional lens index, which is in the red flag, showing that the patient has an internal aberration of the lens which is aging. So clearly this patient needs a cataract surgery more than a LASIK surgery.
Can you just pause here? Because Lucy is here and she's worked a lot on this. Because this is something which a lot of people ask me, is there's a new software in in iTrace, which gives you this whole dysfunctional lens index. Want to know, in America, do you use this? Because he says a lot of people are using this to operate on cataract much earlier. Professor Randleman?
Okay, I haven't used this technology, so I'm a total novice, and I don't know how I would necessarily use this yet. But having not had any experience, I'm probably the one with the shortest answer here. So
this is very important point, because this concept of dysfunctional lens index has brought in a completely new idea into operating patients before it anatomically develops. That's what the question I asked Professor Marshall and Professor Belin, that yes, Lucy, come. Then, sir, please.
Yeah, dysfunctional lens index, I think, is useful in patients who have good visual acuity. They have 6/6 or 6/6 parts, but they complain of symptoms.
That's right.
Okay, and then when you actually look at, if you see that the tear film is normal, the topography is normal, and then you look at the DLI, and then you have a low score, then definitely there is some problem in the lens which is responsible for the symptom. We use both the DLI and also the HD analyzer. The HD analyzer also is a very nice tool which gives you the scatter. So it gives you the OSI, which is the scatter index, objective scatter index. And even in very early cataracts, you can see that or even in very early PCO, you see that the OSI is bad. Patients with very early PCO who come in, they have 6/6 parts vision, but they have symptoms. Now you don't know whether to YAG them or not. So when you do a HD analyzer, then you can actually pick up the scatter, and you know definitely that they're going to improve after a YAG laser. In fact, we did a study on this, very early PCO, which can be picked up with the HD analyzer, especially in multifocal lenses, presbyopic lenses. DLI is useful in cases where you want to document that there is some amount of change. Otherwise, what happens is, especially with the TPAs, now.
Exactly. I'm coming to ask this question.
Yes.
Can you write to insurance that patient has cataract?
Yes, it is a dysfunctional lens. Now, a presbyopic eye is not a dysfunctional lens.
No, I mean, I'm talking about...
Because in a presbyopic eye, the DLI index is much higher, it's usually more than 5. If there is some change in the lens, which is increasing the aberrations or increasing the scatter, that's when you get a low DLI. And that's when definitely the patient may benefit from a cataract surgery if he is symptomatic. Now, it's very subjective because some patients with a lower DLI do not complain at all, but some of them complain of visual symptoms. So if you have a patient who's complaining of visual symptoms and who has a low DLI, then most probably with cataract surgery he's going to benefit.
That's a good point. Lucy, how is this calculated? Because then I'll ask Professor Belin about it. Because like, if we can show from this, how is it calculated? Because this is something which all of us need to know. How is iTrace calculating that? This one, the blue one.
So the blue one that you see, it's the grading of cataract. Here what happens is the light that goes in and comes out, it just measures the scatter of that light, which means it is the block, which means it is the density of the cataract which is blocking. However, the dysfunctional lens index, that includes this scatter, internal aberrations, as well as contrast sensitivity. So iTrace also gives you modulation transfer function, point spread function, and Stirls ratio, which are objective measurements of the contrast sensitivity.
You have to answer this question. The DLI includes?
Yeah, so DLI includes the density of the cataract
this
as well
one.
as, yes, the grade given there. Here it is graded into 5.
Then, yeah, what else does it include? You can show it all on the screen so everybody knows, because this is very important, because if you are going to write it as cataract, tomorrow insurance are going to ask you.
So here, sir, if you see, it gives you a grade. So this is the density changes in the cataract. This density is measured in terms of the light that is getting scattered. And the dysfunctional lens here, it talks about how the lens is behaving like a cataract. So it's not the morphological feature of cataract, but the behavior of the lens. Thereby, it includes the contrast sensitivity as well as the internal aberration along with the density changes. So as sir was saying that OCAS, the optical quality analyzer, gives you the scatter, but the limitation with that is it will not tell you whether the scatter is including the lens or the cornea. It can give you tear film separately, but cannot separate the cornea or the lens. Whereas in iTrace, it will tell you whether it is specifically coming from the lens. So in cases like if you have a LASIK patient who is complaining back and you think it is regression, but you have a dysfunctional lens index coming down, so you know that it is because of the lens. Or as in cases of dysfunctional lens syndrome, like patients who are in their late 30s or early 40s and complaining of quality of vision deteriorating, and you have dysfunctional lens index which is gone down. So even those cases.
So question is, if there is a 42-year-old male with the -5, he comes to you for LASIK, and this is showing he's perfectly all right. Then as a refractive surgeon, what should I treat?
Yes, so this whole concept of bringing this thing in iTrace came because in US, people said that the insurance doesn't cover refractive lens exchange. So how justified are you in leaving your patient with bad quality of vision while driving and not paying the money from the insurance for getting a clear lens extraction? So they started debating this thing. Like the cataract has not developed morphologically to call into a FDA-approved grading of cataract. But then the patient is symptomatic like a cataractus patient would be. So that is still under
the question is still non-answered. If the patient has DLI, should I do LASIK or not when the lens is clear?
So I think to go back to one step, the DLI or this is just an aberrometer.
Yes.
So it's not seeing the lens at all.
Yes.
It's just assuming there's a lens in the eye. So these are 256 points. And each point, how aberrated each point is color scaled on the corneal surface. That's all it is.
Yeah.
Okay, so I'm with Brad that we're not familiar with the software, but correct me. This is looking at total high order minus anterior cornea high
Exactly.
order. And it's completely ignoring a contribution of the posterior,
Absolutely.
which we know is important, particularly the more irregular an eye is. I would tell you, I would be really reluctant to look at something like this and say, I should do cataract surgery based on...
No, so that's a great question. But what we've noticed, this particular graph is just and an assessment of what you would see in the internal aberration profile. You see those graphs with different aberrations. This is just a point-by-point analysis of how bad each point is compared to where it should have been. But the posterior keratoconics are not showing up as internal astigmatism. We know patients with form furrows keratoconus who have posterior elevations or anterior normal corneas. Not many of them are showing up as internal aberrations in terms of coma or astigmatism. Probably.
But we don't know by looking at it.
The challenge here is that if you have this, should we use it or not?
I think so.
Rohit, I think you can also use the pentacam and the densitometry.
That doesn't show.
Yeah.
Sometimes that doesn't show.
No,
This picks up.
but then you can also grade cataract with the densitometry, and definitely if there are changes there in the densitometry, and you can grade the cataract. I think there are a few papers which have kind of correlated log score to densitometry, and it's an objective kind of a way of grading cataracts. And then you also have a high or a low DLI score. Then probably that confirms that, yes, densitometry, and because DLI is more functional.
Yeah.
It's more functional. That is more of the morphology.
Yes.
Where you have
This
actual
anatomic.
changes, yes, anatomic changes.
Yes, sir. So we
Dr.
tried
Kumar?
doing this.
Lucy, 1 minute. He had a question. That's what he said. That's
This is functionality.
see, the debate here. Yeah, we can.
It can.
Again, it's not functionality of the
Who
lens.
is Abhijit? Somebody here can tell, because a lot of people who use eye trace don't use it to measure the accommodation. Somebody here you can tell the protocol of how you measure it eye trace on eye trace?
You have to open up the window and then have a distant
Yeah, we
object.
can
and
have
then
intermediate also. We can do 3 measurements.
So you
and
can-
eye trace can give you a beautiful accommodation measurement.
So unlike other machines which don't have a fixation target, the eye trace has an open window where you can look through the machine at a distance target. And you can put an RAF rule and keep pushing the accommodation and have the patient look at the accommodating target and then keep on doing the autorefractor again and again to see how much aberrations are changing, and more importantly, how much is the myopia it's inducing, the accommodation. So unlike any automated assessment, this is very subjective. So you have the patient look at a distance target at infinity, where you put a 660 chart, then you have an 80 centimeter and RAF, a 40 centimeter, and you can keep on pushing it till the patient can accommodate, truly accommodate.
So, Brandon, do you have anything to say? He asked a question, which I think, what are you measuring, a functional measurement or an anatomical measurement?
Well, this should be measuring a functional measurement. They're not really taking any anatomy into account. I would just say, using our very first lecture today about yoga, I think that this and most of the imaging things will be a good point to say that we should use these in moderation. I don't think that you should be doing, I agree with Michael, I would not do cataract surgery based on my eye trace results. I would use them in conjunction with my physical exam, patient questioning, and a variety of other things. I think this can be useful and additive, but I would not push this, at least today, to the front of the line.
But this has a huge impact if you're doing a presbyopic laser surgery. For example, if you're doing a presby-bond, presby-bax, or anything, on this kind of a patient, because they are clear, the patient is never going to be happy. That's one of the reasons why laser-based presbyopic surgeries has a lot of trouble. The reason being the lens looks anatomically normal, it's not optically normal.
Well, but I would say that that's a different question, because that question assumes that there's no gap between good corneal patients and good lenticular surgery patients. And I think that there still is a gap where someone is no longer a good patient for corneal refractive surgery, but perhaps not yet a good candidate for lens-based. Hopefully that gap will continue to shrink over time, but I do think that gap still exists.
Thank you. Any questions? Yes, Himamsh.
And then you cannot interpret the total elevation from there because the corneal elevation is abnormal. Also, like I agree with Belin, that if you do not have idea about the posterior surface of the cornea, would you be missing out on something? So rather than taking this machine in isolation, I would actually do this. I would also look at the pentagram, look at the posterior elevation on the pentagram. If it is not there.
Well, and in that case, I would say, you know what, most likely it's coming from the internal part, maybe from the lens.
Rohit, the other aspect that you have to consider is you have to look at both the corneal aberrations and the internal aberrations. That particular case, if you bring it up, you can see that though the corneal aberrations and the internal aberrations are bad, when combined together, they look much better. Except for astigmatism, all the other aberrations reduce. So they cancel out each other. So that's something that you need to take into account, because if you are going to treat only the cornea, if you're going to treat only the cornea on topography-based systems, then you're going to make this patient worse, right?
So this is just to bring about the accommodation. So this is one patient where we've done a refraction with the distance target 660 unaided through the hole, where the patient is actually fixating at 6 meters. That's the refraction. And this is when we push it using an RAF rule and bring it close to 40 centimeters. This is about 3 diopters of accommodation that we objective. This is how much the patient accommodated when pushed through.
So
This is, I think all people who use...
I would just come up here. We have been doing this thing, and we have quite a big data of this thing. Abhijit, you all are doing this work. So it's a special, similar to RF rule, a special extension which is there, which goes in the slot of this machine. And we do not do at different distances. We do it at close distance and the far part. No, I mean, the reason behind that, it has variability. So if you try to do it at 30 centimeter, 45 centimeter, you surely can do it, but there are variabilities. But if you want to compare, you have to give a target which is distant target. Again, seeing through that tunnel itself is not good enough, but you have to have a target for distance.
You need a fixation target.
And so a target which is for distance, and that's this thing which comes inside. Again, they have not given the illumination there. It does not work out. If you use the machine the way it has been given, it does not work out. So you have to have side illumination along with that. It may be an external torch light, or it may be an external light source which illuminates the letters on the rule, and then you can do this thing, and it comes out pretty accurate in terms of the accommodation.
Objectively, if you want to find out, you can also do dynamic retinoscopy. I mean, a lot of us don't do dynamic retinoscopy. It's kind of obsolete now, but that is one of the methods where you can actually find out the other way is subjectively, you can make out the amplitude of accommodation by checking the relative positive accommodation, relative negative accommodation by pushing with plus and minus lenses. Sure. So if you minus the positive relative accommodation with the minus the negative relative accommodation, you get the amplitude of accommodation. And this is something which we do in Presbyon. I think Dr. Kudlu is speaking on Presbyon, so he can talk about how we assess functional age, because it's very important to assess functional age and put it into the software.
So Dr. Ganesh, the logic behind this thing is that along with the amplitude of accommodation, we actually see what are the changes which are occurring in different aberration, and which gives a lot of interesting idea about when in future we would be doing some presbyopia treatment, which part to tackle with. So certainly there are other methods which we can do. The interesting part here is we can actually study the different part of the aberrations along with this thing.
Yeah, because we all know that especially the Z4 keeps changing as the lens accommodates. And
absolutely.
In fact, there's some very nice work done by Professor Pelikaris on this change in spherical aberration with accommodation. I think that won the best film at one of the ACRs.
So apart from Z4, the most important part is the spherical part. I mean, that's beyond comparison compared to even spherical aberration. The amount of the range which you have, the change in the direction is actually coming from that part. And when it comes to the actual treatment of presbyopia, if we just keep on looking at Z4 only, we will not have that much range to provide to the patient. And hence, the lower order aberration must come into picture when it comes in the treatment in future.
Lower order, of course you're correcting that in refractors.
I had 2 questions. How reproducible is the image? And secondly, the previous...
How reproducible is the image?
So that's a great question. The DLI is fairly reproducible. If you have tear film disturbances, then you can have changes.
Dependent so much on the tear film. We've seen drastic changes occurring even
So you
in
should probably
normal
repeat.
topographers,
To
placebo
look at
based.
repeatable, so to do any of these measurements, it's not one reading what you take and make a decision, basically. So when you are worried about repeatability, do this, it's very fast. You know, the reading is very fast. You do 3 times, and 3 times if its variation is huge, then you know that it's something to do with your tear film or some other factors.
No, and actually, sir, that's a great question, because repeatability we are discussing in terms of a topography or a pentacam, which is just an objective measurement of a static piece of the eye. Cornea is not going to change, but this is dynamic.
Yes.
So it depends on the mood, time of the day, how much patient is accommodating, on everything.
Exactly.
That is why it's very important to give a target, like Dr. Himanshu had brought about. You have to paralyze accommodation by giving a distance non-accommodating target, and then it will be within range. But it cannot be one measurement all the time, because it's a dynamic thing.
Also, the previous slide that you showed, how do you explain the change in the cylinder with accommodation?
Sure. So
We will
And
come
it's
to
a
that. We'll come to
significant
that
change.
when I'm talking about the nest thing. I'll explain to you about why cylinders should also change. There's something I'm going to show you after we finish.
Yes, couple quick comments relating to that first patient. First, what's interesting from a research point of view, what's interesting from an academic point of view, is very different than what may be applicable in a clinical situation. And I would be really, I'll say it again, leery to apply that example in a clinical situation. I have not used the iTrace in many, many years because, as someone mentioned, I found it not very reproducible. But in that first example, you showed about a 4 diopter change in cylinder going from a 2 to a 3 millimeter pupil. Way back before all these imaging, we did some studies where we used artificial apertures to look at, and I've never seen that much of a change in an otherwise normal patient. So again, I would take this with a huge grain of salt. And you know, I think we're looking at technology to try to justify a surgical intervention, and that's not always the best thing to do.
Any other doubts, questions?
Rohit, 1 minute. See, you just told one word that about this particular case, if you do any presbyopic laser platform, then patient is not going to be happy. Among this overall audience, I feel only 1% of the people might be having iTrace. Definitely iTrace is a good tool. But most of us won't do, some of the patient come back to us with very unhappy. This particular case, my question, without iTrace modalities, with the whatever the regular modalities available in your toolkit, can you able to still go ahead with the laser refractive?
Samresh, this question is for you. He says if you don't have iTrace in this patient, he's come for LASIK surgery, and he has absolutely no idea about his DLI. Nobody has a clue about it. What method do you use to figure out that he has got a lens issue and not his corneal issue? For the time being, we are going by the company's manual saying that this is the greatest tool on earth to pick up lens issues.
That's a great question, sir, and I think that puts me in a fix right now.
Anybody can answer this?
So I think, sir, before iTrace, if I didn't have an iTrace and I didn't know about internal aberrations, if the patient was 6'6", quantitatively, forget quality point of view, I would have gone ahead and done a LASIK for that patient because acuity was fine.
No. Let's take this scenario. This patient is, say, 39-year-old. He's come to you. You don't have an iTrace. Pentacam shows no densitometric changes.
Right.
You have only pentacam, nothing else. The patient has a -3 diopters. The patient says that last 2 years, I'm seeing not so clearly as I used to see, and there is a small change of myopic shift by a 0.25. Now, what do you do? Yes, sir.
So this will not take posterior into account. But
you need to be a little closer. So
the two simplest things are, one, put a bandaged contact lens that will take away surface abnormalities, and put a rigid contact, and that will take away cornea. Now, granted, it's not going to give you, if there's a posterior higher order aberration, but a rigid contact lens over refraction is probably the most underutilized examination technique to separate corneal
I have
changes.
a question for you. If it is a lens, for this discussion, let's take it that it's a lens which is creating a mess, which you're not picking up. How will a rigid contact lens make it more clear to the patient when it's a lens based? The patient
That's exactly the point. 90% of these are not, when you say a young person comes in with visual complaints, 9 times out of 10, It's surface or corneal abnormalities, not lens. And if you put a soft lens and it doesn't improve, and you put a rigid lens and it doesn't improve, there's a good likelihood that it is lens. And you'll be amazed at the improvement you'll get on many pathologic conditions. Even patients, we looked at some of our retina patients who've been diagnosed with AMD, and we put a rigid lens on them. It's amazing what improvement in visual quality you get.
But I'll ask you a question. If this patient has no corneal issues, you put a contact lens, and still the patient has no, it's not clear. So now what do you blame? You blame the lens?
Well, obviously the answer is it would raise my suspicions that it's lenticular. You know, I would like to obviously see something in slit lamp. I do occasionally use the Pentacam densitometry of lens.
It's normal. Let's assume for this thing. I go by what Professor Marshall said.
Then I would send him to a neuro-ophthalmologist, believe it or not.
I think, Rohit,
I have a great takeaway.
I think a good streak retinoscopy, you can pick up a lot of things. So you dilate the patient. It needs a high degree of expertise and awareness, but sometimes you can look at the movement of the streak, the shadow, the speed of movement, and the brightness of the reflex. You can pick up subtle changes in the lens which can point to this. So this is a lost art, but if for somebody who is doing like hundreds of retinoscopes, dilated retinoscopy, you can pick up small subtle changes.
So we had 2 points today. One is the contact lens you pick up. The second point is the you have to do your own retinoscopy or the optometrist and pick it up, and you see the dull reflex which is happening.
Even the speed of movement and then relative movement of the center to the periphery, you can pick up even abrasions.
You have any
just to take away from Dr. Belin's point, I think he had a very valid point. You don't need to have this machine in the clinic all the time. If the patient comes to you at that age bracket, if the patient comes to you and wants a LASIK, the vision they're going to get after a LASIK is more or less the vision they're going to get after putting a contact lens. And even after a contact lens, if the vision is not that great, I would be wary of doing a LASIK on that patient. Because that's how you're doing. You're treating the cornea, and then the patient is not happy. Something's going on inside the eye.
I think for a lot of friends here, I go by what Professor John Marshall said. We are aging optically early. I mean, that means that the DLI, which a lot of us consider as useless today, will be probably the most useful. I'm not talking about DLI in this avatar. I'm talking about DLR in some other avatar. The reason being, we seeing presbyopia much earlier because people start working at the age of 10, 9 with systems. So, Professor Marshall, would you like to comment on this? You think the what we call it as the cutoff at age is 40 is going to be not just the presbyopia. I'm talking about. I don't think you believe in this, but for the minute, you believe in this and you accept that there is a changes of optical lens happening. Do you think that we will get early all these problems because we are working on this near vision for a longer time at much early age group?
There's an increasing body of evidence which seems to suggest that. But I think, you know, surrounded by an audience of ophthalmologists, you guys are sort of confusing a number of different issues here. And you're confusing diagnosis with treatment in some ways. And you know, it's always been my maxim, why punish the cornea for the crime of the lens? And you know, you can, as you take the lens out and throw it in a bucket and put a new one in or whatever. And we're getting more and more sophisticated measurement techniques and more sophisticated surgery techniques. But at the end of the day, presbyopia is the loss of a dynamic process, accommodation. And in terms of patient happiness, they're never going to be really happy with a series of click stops. You know, but what patients really want is to replace what they've got again with a new system, which they're not going to get for a long time. So I think this is a very useful device, but as we heard earlier, it's function that's important, and it's the functional element, I think, that is most important here. But when I come to my cataract surgery, I tell you, and I don't need it yet, I'm going to go for a straight sphere and spectacles.
Anybody else? Mukesh, you have any other point to find this? Forget eye trace. We don't have an eye trace. Yes.
I don't have the answer to this, but for those of you who utilize this, I would ask you to look at the patients you think this is telling you to do cataract surgery based on the hyoid aberration, and then do the same test after you put in your multifocals